Salivary gland this morning. Start with cytology. So actually this is a big part of our FNA business that we, like when we personally do the FNAs, pathologists personally do them. And the advantages of getting an FNA is that it's easy, fast, safe, and very well tolerated by the patients. You know, it's one of the things I tell the patients, it's one of the few procedures where you actually walk away with just a Band-Aid. You know, it's kind of nice. It's accurate. And this depends on how you define accurate, but as long as you're talking about, you know, basically we want to know, is it a salivary gland neoplasm versus something else, then yeah, it's very accurate. It can allow the patient to avoid surgery. It can also alter the surgical approach. For instance, if something's high grade, the surgeon will take out the facial nerve as well as the gland involved if it's a parotid gland tumor, whereas if it's a low-grade thing, they'll try to leave that nerve alone. And that has consequences for the patient because there are a lot of motor functions that go through that nerve. So, you know, you'll be left not be able to feel a part of your face or not being able to move a part of your face as well as you used to. So there are consequences to the diagnosis that you render on FNA. The indications, the most important one is to tell them is something benign or malignant, and if it is malignant, if it's high grade, and then the other thing is if it's not a neoplasm, it turns out sometimes there's a lymph node inside the parotid gland that can get large, you know, just like lymph nodes when you get sick, and sometimes that's all it is, and then you can avoid surgery altogether in cases like that. Or if it just turns out to be a salivary stone, a sialolith, or something like that. So in high-risk individuals, you could avoid surgery if it's benign, if you can say with confidence that it's benign. And then you can also modify your management, like I was talking about. So anatomic considerations. The larger salivary glands that we FNA with frequency are the parotid, the submandibular, and the submental glands. There are other minor salivary glands that are present in the oral mucosa and tongue, and it is possible to FNA those, although it's a little bit trickier, and it involves going, you know, inside the patient's mouth, which it can be a little bit disquieting for the patient. Intercalating. Okay, so you have the intercalated ducts, the connected striated ducts, and the salivary acini, where the actual enzymes are produced, and that's where most neoplasms come from. And then you have your serous, mucinous, and mixed acini. The parotid gland, which is this gland here, has mostly serous. The submandibular, which is here, has a mix of the two. And then the submental tends to be mostly mucinous. And most of the minor salivary glands also are mostly mucinous. The serous is responsible for producing the watery saliva that most of us produce throughout the course of the day or right before we're eating, things like that. Whereas the mucinous acini produce that sticky stuff that you're, like when you first wake up, that's the mucinous stuff at work. Or when you're really stressed out and you get cotton mouth, that's mostly mucinous acini at work there. So this is the anatomy, which I already kind of mentioned. Sometimes you get an accessory parotid gland along the course of that parotid duct, which is the longest salivary duct that we have. And that can cause neoplasms too. So sometimes they're in a weird place, but that's how it looks. So this is a mixed serous mucinous area, and most commonly that would be in the submandibular gland. The mucinous are the ones that look very foamy and very cleared out, and then the serous are the ones that have this kind of granular metachromatic look to them. And those, the granularity is because of what are called zymogen granules, so the precursor of the salivary enzymes are in there. And then when they're released into the duct, there are enzymes present in there that cleave them into their active form. And those are the enzymes that produce amylase, that break down starch. I don't know if you guys have ever done the experiment where you chew a cracker long enough and it becomes sweet. That's amylase. And other enzymes as well that start the digestive process while you're chewing your food. Okay, so acinar cells are cohesive ball-like formations, lobules that look like a bag of grapes. And they have serous, mucinous, and there are some oncocytic types of cells as well. The ductal cells start out cuboidal and then become columnar as you get into larger and larger ducts. And then they're frequently monolayer and flat honeycomb type sheets when you see them on cytology. The myoeps are the elongate, almost look like spindle cells. They have oval nuclei and not too common to see in a normal aspirate, but they are kind of a reassuring sign when you see them, especially near the ductal cells, that everything's okay. Adipose tissue is often present, and then you can get naked nuclei of your damaged acinar cells. So the acinar cells, those zymogen granules don't always hold on to the nucleus very well, and sometimes the nuclei will be just kind of out there by themselves. And then if that happens, there'll be a granular background. You'll see debris. So this is a normal acini, probably serous. You can kind of get a kind of feel that there's granularity to the cytoplasm. But you'll see these nice round acini, very bland-looking cell morphology there. And every once in a while, if you look carefully, you can find a myoep around those. And sometimes you'll actually even be able to see some of the intercalated duct cells. These may be intercalated duct, but it's hard to tell. Okay, so your inflammatory lesions, this is this kind of stuff you don't need to do surgery for. Acute sialadenitis, which can be viral or bacterial, can be due to trauma, bad oral hygiene, so the tooth abscesses can back up into the salivary glands and cause inflammation. Sialolithiasis, which is salivary duct stones, and dehydration. Usually the ducts will become, or the glands will become diffusely enlarged and often bilateral. So that's a common cause of bilateral swelling of the glands. There will be a lot of, if it's acute, there will be a lot of neutrophils and less lymphocytes, histiocytes. There often is a lot of necrotic debris and very few ductal cells. So this is what that looks like. You can get a fragment of a stone or some debris, and then just a lot of neutrophils in the background. It basically looks like you've tapped an abscess. So, chronic sialadenitis is usually due to either the sialolith or X-ray therapy. Radiation therapy, usually to the submandibular gland. Why? Because that's where the submandibular gland is the location of about 2/3 of malignant salivary neoplasms. So that's important to know. Symptoms: recurrent swelling and pain can present as a discrete mass. You'll see lymphocytes and macrophages. Often there's fibrosis, which actually makes it tough to get good material. So sometimes these end up being non-diagnostic. And the other thing to know is that you can get some atypical squamous cells with these guys, and it can lead you to the false impression of malignancy. So here is an example of the chronic sialadenitis. You've really got just some vascularity and fibrosis with mostly inflammatory cells in the background. It'll be difficult to get acini or ductal cells in those, and that's why a lot of them end up being called non-diagnostic. Granulomatous sialadenitis can be due to infections, numerous types, sarcoidosis, a ruptured cyst, which causes foreign body reaction, or some other neoplasm. With tuberculosis, the parotid gland is the most often involved gland. It's not something you see very often in the U.S., though. Cytology, you get a mixture of acute and chronic inflammatory cells. You get the aggregates of epithelioid cells, which look like granulomas, the multinucleate giant cells. You can have debris in the background. And seeing organism with stain is rare, but you do look for it. And then the most common way they make the diagnosis if it's infectious is by culture. So this is what a granuloma looks like anywhere in the body. Just know that, and you'll be able to say, oh, it's granulomatous something. Okay, so lymphoepithelial sialadenitis used to be called benign lymphoepithelial lesion, but now has gotten this name. Mikulicz-Sjogren syndrome is the most common cause of this. You get symmetric, again, bilateral and symmetric enlargement of the salivary and lacrimal glands. These patients tend to have dry mouth, dry eyes, and basically dry mucous membranes. So, and they often have some other autoimmune disease. It often comes with other things like lupus or rheumatoid arthritis. And this is most commonly seen in women in their 40s to 50s. So you get the most important thing that you see here is plasma cells. That's the clue that it might be this entity. Otherwise, it looks like chronic sialadenitis. And the other thing is, if the lymphoid population is very brisk and intense, you may have to consider a malt lymphoma, which do arise in this context. So people with Sjogren's syndrome get this entity, and if the lymphocytes overgrow and start to become monoclonal, you can get a malt lymphoma out of this. So it can be a difficult differential diagnosis. So this is the basic. You just see lots of lymphocytes in the background. It's kind of hard to tell here, but there are plasma cells, and that would be the clue that you're dealing with LESA. Often, again, there's fibrosis, just like you see with chronic sialadenitis of other cause. Chronic lymphadenitis of intraparotid lymph nodes. This is a nice way, and probably the most common, you don't have to operate thing that we diagnose in FNA. They tend to be cellular, tend to be a mixed population of cells. Basically, it looks like you aspirated a lymph node, because you did. So there's very little else, and the differential will be lymphoepithelial sialadenitis, which would have more plasma cells than a regular lymph node. Plasma cells aren't typical in a lymph node. Lymphomas, where the populations would be more monomorphic than what you see in a lymph node. Warthin's tumor is always in this differential, and what you'll see there are oncocytes in addition to your lymphoid cells, and then chronic sialadenitis. So other non-neoplastic things you can see are cysts. Sometimes there will be an obstruction because of a silolith in the duct distal to where the cyst forms, and it will back up and cause that. Mucoceles, which are just when the mucus is extravasated, not out of the cells into the ducts, but it just kind of goes out into the space, tissue space. You can get a pseudocyst from that. A ranula, which is a similar thing in the floor of the mouth, which can actually make the tongue, it kind of displaces the tongue upward, and it's very uncomfortable for the patients. They usually come in with a cyst in the bottom of their mouth. And then lymphoepithelial cysts, which are actually associated with HIV. And on the aspiration cytology, you'll just have a lot of fluid and squamous cells, which may be atypical inflammation, and can vary with degree of duration of obstruction. Oh, and foamy macrophages are also a common finding, as with any cyst anywhere in the body. Mucoceles, so foamy macrophages, common, and other inflammatory cells. Again, like with cysts anywhere else in the body, what often happens is they end up being non-diagnostic because you don't see the epithelial component of the organ you're in. And you just say macrophages and inflammatory debris, and you'll say in a comment, these could be consistent with cyst contents, but clinical correlation is recommended, and repeat the FNA if the cyst reaccumulates, essentially. Okay, benign lymphoepithelial cyst, again, a lot of these have been reclassified as the lymphoepithelial sialadenitis. Depends on if you see plasma cells or not. And the lymphoepithelial, some lymphoepithelial lesions are associated with HIV, so keep that in mind. Benign neoplasms, parotid is the most common place to get benign neoplasms. So most things in the parotid are benign, and most things that are benign are in the parotid. Common stem cell abductal epithelial and myoepithelial cells are thought to be the precursor cell of most of these. And of the most of the benign ones, the most common is pleomorphic adenoma, which is probably better termed benign mixed tumor. So the reason pleomorphic is usually a term we use to associate with malignancy, and it's not in this particular entity. The word pleomorphic was not intended to apply to the cells of the lesions. It's tended to apply to the fact that different lesions can look very different from one another. Because it's a mixed tumor, it's basically how much of the mix is one type of cell and how much is another type. So when the person named this, they were actually talking about the variable appearance tumor to tumor, and that's how it got its name. So 40 to 60-year-old female predominance, solitary, well circumscribed, painless, and slow-growing mass. They tend to recur if you don't completely excise them, so they do get operated on. They have these removed. And part of the reason for that is because there are rare cases where you get carcinoma arising in one of these. So if you ever hear the story of a slow-growing mass that suddenly became faster-growing, that's a common thing where carcinomas arising in one of these. It tends to have a very bosselated or variable-looking external surface, lumpy, bumpy, 2 to 6 centimeters in diameter, can be solid, can be cystic. The aspirate often has kind of a jelly-like consistency to it, and it tends to be quite cellular. You'll get a mixture of epithelial, myoepithelial, and the matrix, which has a very distinctive fibrillar, looks like the hair on a troll doll kind of appearance. Epithelial cells tend to be cuboidal and very cohesive. They're round nuclei with ill-defined cytoplasm. And it's not uncommon to see some cellular atypia in these things, which can bring up the question of carcinoma X, pleomorphic adenoma. Myoepithelial cells tend to be spindled to plasmacytoid, often trapped within the matrix, which is a very helpful finding, trying to distinguish this from some malignant things that we'll touch on later on, is that in pleomorphic adenoma, the cells tend to be embedded within the matrix, whereas in some malignant things, the matrix has no cells in it at all. So this particular entity has dense fibrillar matrix that is metachromatic, meaning it stains with both the stains on Diffquick, which makes it a kind of a magenta color. And then it's very pale and hard to see on the PAP, but when you do, it's kind of a bluish tint. Differential adenoid cystic is the biggest one, which also has matrix, but the matrix of adenoid cystic is hard and usually forms spheroids, whereas this one is nice and fibrillar, troll hair-like. Then you have mucoepidermoid carcinoma, monomorphic adenoma, carcinoma X, and other entities. Sometimes basal cell adenoma, basal cell adenocarcinoma can come in the differential. So this is the matrix. It's very classic, very fibrillar in appearance, and not the spherules that you see in adenoid cystic. Also note again that you often have myoepithelial cells embedded within your matrix. This is a beautiful example where you get that nice troll hair. See how that looks like, kind of like those troll dolls. And you get these nice kind of regular appearing basaloid cells in clusters, very cohesive. And within the matrix, you see your myoepithelial cells. Okay, really nice example here. Now, this is what I'm talking about. The matrix still is present in the PAP, but it's not the predominant feature anymore. The cells stick out more than the matrix does. And you can just reassure yourself that the cells have usually a pretty basaloid appearance. They're usually not terribly atypical, although you can see 1 or 2 atypical cells here and there. Really nice example, basaloid cells in tight cohesive clusters, tubular formation, and then your myoeps embedded within the matrix. This is what they look like on histology. Often the matrix component in histology has a cartilage-like appearance to it. It can be vascular, or it can just have a lot of ducts kind of embedded within that chondroid matrix. Monomorphic adenoma is just whenever there's a single cell type that's basically so predominant over the picture that you don't really have the other components. Some people have said it might be an early phase in the development of pleomorphic adenoma, like the cells kind of go along one line and then they start to differentiate into other things. What you see as the predominant is the basaloid cells, which can be singular in cords, usually more cohesive, but a very uniform cell population. Cytoplasm is scant, and then subtyped according to which type is the predominance. So if it's the basal cells, basal cell adenoma would be the name. If it's the myoeps, myoepithelioma. There are other types. Canalicular adenoma is just basically a pattern that the basaloid cells like to make. And this is what it looks like. So the one thing that's kind of, the matrix tends to be a lot less. You don't see as much of it. So that's kind of one hint. And one thing we can always do is just call it a basaloid salivary neoplasm, which will include basal cell adenoma, your monomorphic adenomas, plus pleomorphic adenoma with basal cell predominance. So that can be very helpful as a tool to sign out. You can get this basement membrane material wrapping around the basal cells. That often brings up the question of, it can bring up the question of adenoid, cystic, or other malignant tumors. But in this case, as long as the cells are really bland and you don't see the adenoid cystic matrix, which I'll show you later, it's probably okay. So Warthin tumor is the second most common benign salivary neoplasm, and it's also a painless, slow-growing mass. Tends to occur in the same populations, except this one is male predominant, as opposed to the others, which were female predominant. They may arise from benign ductal inclusions in intraparotid lymph nodes. That's not entirely clear. They tend to have a cystic appearance between 3 and 5 centimeters and encapsulated, and the cyst fluid has this classic motor oil-like consistency, so when you draw it up into the syringe, it looks like motor oil. That's a good clue that this is what you're dealing with. And it's easy to remember because it's well associated with smokers. So the oil kind of looks like what you see at the bottom of an ashtray, or that kind of color, so it's just easy for me to remember. So watery, mucoid, brown, aspirate, and it looks like sheets of oncocytes with abundant granular cytoplasm and distinct cell borders. It basically looks like when you aspirate lymphocytic thyroiditis. You get oncocytes and lymphocytes. So the nuclei around oval, finely granular chromatin. You can't have nucleoli, you can't have nuclear atypia, just like with lymphocytic thyroiditis. Those oncocytes, the hurdle cells, can look really funny sometimes. And so you get the same kind of thing. Mixed population of lymphocytes and amorphous cellular debris in the background. And the Warthin tumor is the most common name for it. The other term is papillary cystadenoma lymphomatosum, so that's a mouthful, so people just like to say Warthin tumor. So there you go. You've got your oncocytes, you've got your lymphocytes in the background, and this is what they look like on PAP. So PAP kind of shrinks them up a little bit, but they still have quite abundant eosinophilic cytoplasm. Again, this is another example. So plump cells, lots of cytoplasm. They look kind of granular on the PAP. You look close, a lot of these will have small nucleoli, and then you have your background of lymphocytes. Oncocytoma is basically, looks like a Warthin tumor without the lymphocyte component. It's not very common, and when it does occur, it's going to occur in the parotid gland generally. So it can be very cellular, but again, you won't have the lymphocytes in the background. So the differential will be Warthin's tumor and Acinic cell, particularly if a lot of the cells have naked nuclei. That can be kind of tricky. But they usually do have abundant cytoplasm and nucleoli, just like the hurdle cells in the thyroid gland, and that's the clue. Without the lymphocytes in the background, oncocytoma would be your favorite diagnosis. Mucoepidermoid carcinoma is the most common salivary gland malignancy in both kids and adults. It can occur in kids. That's the one thing to keep in mind. It tends to be most common in the parotid gland. They are low grade. Most of them are low grade. When they will recur locally and not metastasize. When they're high grade, they grow very quickly and they will metastasize. So you can see the big difference between the survival, which is why remember I told you the surgeon's going to want to know the low grade versus high grade thing, because remember they're going to take that nerve if it's high grade, and especially in a kid, they're going to have the rest of their life not being able to feel part of their face or be able to make certain movements. Smile's going to look a little funny and that kind of thing. So the low-grade cytology has a background of mucus and debris with mucus cells, which are vacuolated. They're basically goblet cells or goblet-like. Intermediate cells, and then squamous component, which it can be sparse, but it's very helpful when you see it. And the most common cause of a false negative FNA, because the cells can look somewhat, they're low grade, so they can look kind of bland. High grade is like, you know it's malignant immediately. It's usually not difficult to get to high grade malignancy. It can be a little bit difficult to get to mucoep, and the one clue is the really atypical squamous cells. In which case, you know, you'll have to think about squamous cell carcinoma itself. So what you look for are those glandular components as well, and they can be hard to find. So sometimes you have to say a high-grade malignancy differential includes mucoep and squamous. But if it occurs in a child, of course, you'd favor mucoep because they don't get squamous cell carcinoma that early. Okay, so these goblet-like cells or mucus cells are an important finding, and that's very helpful if you've got that. And then high grade is just like ugly malignant. So that's not the hard part. The hard part is getting to mucoep, and the key to that is finding some glandular differentiation. Sometimes you can do like a mucocarmin or something like that to get you, so you can see some of the cells are producing mucin, and that would be helpful. Acinic cell carcinoma is the second most common salivary gland malignancy. These also can occur in kids, but a little bit more common in adults. So they tend to peak out in the 40s. They tend to be female predominant, like most salivary tumors. What's the exception? One that's more common in males? Smokers? Warthins, right, yeah. Okay, so acinic cell tends to be slow growing and asymptomatic. And when I say slow growing, I mean slow growing. So sometimes people will come to you with having had one of these for 10 years. And they'll be like, you know, it's just kind of gotten, you know, irritating now. And the other thing about it is that when you remove it, it can be a very long time before they recur, up to 20 years. So it's one of those tumors that you don't let the patient go after 5 years, say you're cured, be gone. You actually have to follow them for the rest of their life and look for recurrences. And that's why the 5-year survival is great, but the 20-year survival not as great because of these late recurrences. The aspirates tend to be cellular, and this is kind of a clue. They'll be more cellular than what you'd expect to see in a benign salivary gland. But the elements very much resemble, remember, acinic cells are the most common cells aspirated in benign gland. So they can be very similar in appearance to benign acinic cells. And the key is going to be the cellularity. They can have large cells. They tend to have more abundant cytoplasm, the distinct cell borders, and they have that zymogen granular appearance. Naked nuclei are often seen because these cells are a little bit more fragile than normal acinic cells. So that can actually cause confusion with like a lymph node, because you know the lymphocytes are small and the nuclei often are naked in those as well. So one thing to look for is your background. Sometimes a bloody background can be helpful, or those zymogen granules will create a granular background. And well-differentiated tumor, again, can resemble normal Asner cells, but tend to lack ductal cells or fat in the background. And again, the lymphocytes can be present in the follicular variant, which even makes it a little bit harder. You know, you could misdiagnose this as an intraparotid lymph node. So it's one to be wary of. Now, if you're lucky, it looks like this, and you can tell, well, these are all Asner cells, and in an overall really cellular smear, you'd be like, well, this is too much. Why am I seeing all this? And I'm not seeing the intercalated ducts. So that can be a useful feature. This is kind of the usual picture you'll get. So there's this kind of overall granular sheen to the slide, and a lot of these cells will have lost some or all of their cytoplasm. So you can get a lot of naked nuclei in the background. This is a papillary variant that you can see, and it's very helpful when you do, because nothing looks quite like it in the salivary gland. It's very diagnostic. The cells, again, have abundant cytoplasm, nice and granular look to them. So adenoid cystic. This is a little bit the third most common malignant tumor, and tends to occur, it can occur in the parotid, but it also tends to occur a lot in the submandibular gland. About 30% of minor salivary gland tumors, and slow growing. Pain is common in presentation because it has a very strong tendency to invade nerves, and it does this very early. It also has a poor prognosis. Again, like a acinic cell, it can recur late, and it just tends to be relentless. So they cut it out and it recurs somewhere, and then they treat, and then it recurs again, and it just goes on and on. Cytology, very cellular. You get these uniform basaloid cells with scant cytoplasm, and then this time the matrix appears as spherules and tends not to have cells embedded within it. So it's a very classic appearance here. So these cells usually surround the matrix but aren't in it. Every once in a while you might see what looks like a cell in it, but if you focus up and down, you'll realize that it's either on top of it or on the bottom of it, but not in it. So very, very classic appearance, these spherules of matrix with cells around them, basaloid cells around them. This is what it looks like on DivQuick. Again, your matrix tends to go away or not be as clear. Sometimes you can see it a little bit better here, but the cells tend to be very monomorphic, which can cause confusion with benign entities. Primary squamous cell carcinoma within, this is squam, right? Yeah. Within salivary gland, it is rare. It's more common for tumors to involve that from somewhere else. So the most common place for squams to occur are in the tonsils in the back of the throat and in a ring of tissue in the upper soft palate. So when you see this, the most common thing is going to be embedded there, and they're going to have to exclude that clinically. It tends to be cellular. If you're lucky and it's well differentiated, you get keratinization and it shows up orange on the pap, which is great. The differential is going to be metastatic, high-grade mucoep, as I explained before, and squamous cell arising from an otherwise pleomorphic adenoma. So you're going to want to look at your background cells, your benign cells, and see if there is evidence of pleomorphic adenoma in the background, where that would help you kind of say this probably is primary to the salivary gland. Okay, so these tadpole cells, just like you saw in squams and paps, same kind of deal. If you're lucky, they keratinize. If not, you can have the robin's egg blue cytoplasm, and that can help you, and that grungy necrotic background that they always have. Carcinoma ex pleomorphic adenoma, we've already mentioned. That's when carcinoma arises in a pleomorphic adenoma, so you get the history of a slow-growing mass that suddenly becomes rapid in its growth. 5-year survival isn't great, and it tends to have a mixture of benign and malignant features. So you have the background of pleomorphic adenoma, and then you have the malignant cells as a second population. So squamous is the most common, but you can get adenocarcinomas from these two. And it's hard to make the diagnosis by cytology. Usually you just make the diagnosis of malignancy, and then they'll cut it out, and then you make the better diagnosis on histology. As long as you can get to malignant, that's really the key. And it's usually not difficult. This is probably an adenocarcinoma arising, because this has more of a foamy, kind of difficult to see cytoplasm. Then this is, again, you have your stromal fragments with myoeps embedded in them, which tell you that there was a mixed tumor here. And then you have your malignant cells here. So I can tell you, okay, carcinoma X. Adenocarcinoma NOS. These tend to be salivary ductal carcinomas. So they can arise in the minor salivary glands. Most have some evidence of mucin production, which is useful. And they, again, can be low-grade or high-grade. Polymorphous low-grade adenocarcinoma is almost impossible to distinguish from adenoid cystic on cytology, so you usually give it as a differential. They tend to be small. The one thing, if you saw mucin production, I guess that would help. But mucinous columnar cells. So this is their appearance. They can be kind of loose around the edges, so a little bit looser than what you see in the normal basaloid neoplasms, bloodier background, all that good stuff. And if you get up there close, you'll see that they have malignant cytologic features. Okay, metastatic neoplasms. They're kind of common in the parotid because of that intraparotid lymph node I told you about that, is a benign finding. But since you have a lymph node there, you can get metastatic things to that. The most common thing, because of the head and neck, the most common tumor of the head and neck is squame. The most common thing to the parotid is squame. Malignant melanoma also, as it makes its way to the brain, it can stop in one of these intraparotid lymph nodes. Or if you get one in the neck, sometimes they'll end up there. Less commonly, you can see kidney renal cell carcinomas can metastasize anywhere, so it's not a surprise. Breast, same thing. You often see skin mets in these people too. They'll have like a growth on their forehead or something like that, and it turns out to be metastatic kidney or breast carcinoma. Stomach, lung, and pancreas would be less common, but they all can happen. And what's even scarier is sometimes they don't know about their primary tumor, like in the case of stomach, so that can be very tricky. Metastatic melanoma, if you're lucky, you'll see the pigment. If you're not, you won't, which is most of the time. But the helpful features are these plasmacytoid cells, really big, prominent nucleoli, and occasionally, not in these pictures, but inkies are common in melanoma. Again, there's an inky, so that's a common finding. And if you're lucky, you get pigment granules. This also can be a spindle cell pattern can be predominant. There's pigment. It's always nice. You got it. Mesenchymal tumors. So benign mesenchymal tumors, lipoma. Remember, there's fat around those glands, so you can get lipomas in that fat. Neurofibroma or schwannoma. Schwannoma is the painful one. Remember, if the patient tries to punch you while you're doing the FNA, it might be a schwannoma because it hurts so much. It's basically a nerve tumor, and so there's always a nerve right there somewhere. So you can't help but hit it. Juvenile hemangioma is a benign tumor. That's usually the tumor if you see a strawberry patch on a kid's face, and this is the tumor where the parents freak out because the kid looks funny, he's got this big red patch, and it turns out that the tumors tend to go away with time. So the doc usually tries to reassure them and get them not to do surgery, although there are places now where you can get surgery for kids who have these. But they do tend to go away on their own, and they usually fade in appearance and they're gone by the time the kid's 9 or 10. And then the malignant mesenchymal tumor that's most common is neurofibrosarcoma, or MPNST, which is malignant peripheral nerve sheath tumor. That's the preferred term. I don't think neurofibrosarcoma is used very much anymore. So schwannoma looks like this. It's just classic in appearance. These basically spindle cells that look like they're being pulled apart. And this is the histologic appearance. These things with the spindle cells that kind of palisade on both sides of this cleared out area are called Verricae bodies. And other neck lesions you can see, thyroglossal duct and branchial cleft cyst. Those are both cysts that are lined by usually squamous cells. And the difference is thyroglossal duct is in the midline between the thyroid and the tongue, thyroglossal. And then the lateral is your branchial cleft cysts. That comes from the branchial clefts in fetal development. Epidermal inclusion cysts, which are they usually are just round, kind of fluctuant masses which can be on the face or around the lymph node or neck. Other lymphomas that we already talked about. Paraganglioma and carotid body tumor. That's interesting because that's the one thing you don't want to FNA. There are two reasons. For one thing, it's right next to the carotid artery, so you don't really want to stick that if you can help it. Although, surprisingly, you don't necessarily bleed to death sticking the carotid artery. What usually happens is it'll clot off unless the patient has a problem clotting, and they'll actually be okay. But it's not good for them to have something spewing out. But the other thing is a carotid body tumor is a type of paragangliomas. So paragangliomas usually have the capability of releasing epinephrine and norepinephrine. So what happens is you stick this tumor, and their blood pressure goes through the roof. So that's really why it's contraindicated, not so much because you can hit the artery. Parathyroid cysts and tumors. Parathyroids don't always. They're usually right next to the thyroid gland, but they can occur in other places. You can get ectopic parathyroid tissue, so sometimes that gets confused with salivary mass. And then various kind of cysts. Epidermoid, which is basically the same as epidermal inclusion cyst, and dermoid cyst has sebaceous glands in it. Salivary gland masses that can have cystic change in them, the lymphoepithelial cysts you can see in HIV, mucoceles, which is really kind of a pseudocyst formation, just the mucus is outside of cells and accumulating. Pleomorphic or monomorphic adenoma can have cyst change, and Warthin's tumor obviously has that motor oil appearance, and when it has a cystic component. Low-grade mucoeps, acinic cell carcinoma, and then squamous, primary metastatic. These basically, the cystic change is just necrosis forming cystic areas. Lymphocytes on salivary gland, what kind of things can cause that? Chronic sialadenitis, lymphoepithelial sialadenitis, lymphoepithelial cyst, Warthin tumor, acinic cell, lymphomas, and then just having an intraparotid lymph node. Summary of salivary gland FNA. So there are really a lot of primary epithelial tumors. There's a laundry list. We've just covered the most common ones. The good things to remember are most of the things in the parotid are benign. Most of the things in the submandibular gland are malignant. Most of the things in the submandibular gland that are malignant are low grade. So they're not all overtly malignant, so you have to kind of look. You have to be wary when you're looking at a submandibular aspirate. High-grade malignancies can be difficult to distinguish from one another. So you're like, I know it's malignant, can't tell what kind of malignancy it is. You end up signing it out as high-grade malignant cells present, and that's good enough to get them the surgery they need. Some benign tumors do have malignant counterparts, and they can be they're almost identical or even identical cytomorphologically, which is why we can sometimes use, hedgy terms like basaloid salivary neoplasm. And we'll even say in the comment, this differential includes benign and malignant tumors. Sometimes that's as far as we can get. And many salivary gland tumors can have similar cellular components. The things we try to distinguish are neoplasm from non-neoplasm. That's probably the most important branch point, because if it's not neoplastic, then there's no need for surgery. And then benign or low-grade neoplasm from high-grade neoplasm. And you notice benign or low-grade is kind of lumped together, and there's a reason for that. A lot of times we'll just say, it's a salivary neoplasm, we favor it's low-grade or benign, and that's enough to get them a surgery. Like I said, most, like pleomorphic adenomas, they're still removed because they can become carcinoma X. So that's going to get them the surgery they need, which is a low-grade resection sparing that nerve. And then if you can tell those guys from the high-grade malignant, that's all the surgeon really needs. So special problems, again, basaloid neoplasms. So that's that differential between pleomorphic adenoma, adenoid cystic, and basal cell adenomas, other monomorphic adenomas. Sometimes we just say basaloid neoplasm. Mucus-containing lesions, another difficult to distinguish area because that can be adenocarcinoma versus Mucoepidermoid, versus something else. A lot of, again, most parotid tumors are benign, most salivary or submandibular gland tumors are malignant, and most of the minor ones as well, most of the ones in the minor salivary glands are malignant. So the incidence, you can think of it as the incidence of malignancy increases as the size of the gland decreases. All right. Any questions?